Today we have two PGY5s presenting on our standard format, one long and one short article. Dr. Dmitry Petrov, PGY5, will start with a systematic review of LDL lowering in older adults. Dmitry, over to you.
Thank you so much, Dr. Gandel, and good morning, everyone. So today I'll be presenting a short presentation on the efficacy and safety of lowering LDL cholesterol in older adults. I have no conflict of interest. So let's start briefly with a case review. We have Mr. DL, who's a 78-year-old man living at home with his wife. His wife is assisting him with managing finances, cooking, and housework, but he's independent for ADLs. His past medical history includes hypertension, dyslipidemia, coronary artery disease, type 2 diabetes, and mild Alzheimer's dementia. And you're asked to review his medications for polypharmacy. Of course, part of his medications is atorvastatin, and the question that we'll address today is, would you discontinue his atorvastatin, given his age and his comorbidities? So what the kind of evidence we have so far shows that the Canadian Cardiovascular Society guidelines for management of dyslipidemia recognize that there's a limited amount of data specifically for adults 75 years or older. In fact, we often make treatment decisions based on assessment of risk, and the most commonly used risk assessment tool is the Framingham Heart Study Risk Score, which unfortunately hasn't been validated for patients at age 75 and older. And so currently the Canadian Cardiovascular Society guidelines suggest that older adults aged 75 and older should have an individualized approach with risk-benefit discussion. In terms of use of lipid-lowering therapy for primary prevention, a systematic review done by Severis et al. In 2013 looked at 8 trials of approximately 24,000 individuals at high cardiovascular risk, but no history. The mean age of the participants in those studies were 73, and mean follow-up was 3.5 years. So the systematic review was able to show benefit of risk of myocardial infarction and stroke, but there's no significant benefit in all-cause mortality. When you look at secondary prevention, the Canadian Cardiovascular Society guidelines state that a composite mortality benefit has not been shown with LDL lowering therapy in individuals who have history or risk factors for vascular disease. And they largely made this statement based on the results of the PROSPER trial. Since then, some further evidence has been presented, and there's a very good 2019 meta-analysis done by the Cholesterol Treatment Trialysis Collaboration. They looked at about 14,000 individuals altogether, and they were able to show a reduction of major cardiovascular events by 21% per 1 millimole per liter reduction in LDL cholesterol. However, there was some attenuation of benefit with increasing age. So based on this evidence so far, I think it will be useful to review this new study that came out. And this is a systematic review and meta-analysis study of randomized controlled trials looking at efficacy and safety of lowering LDL cholesterol in older patients. The study objective was to summarize the evidence of lipid-lowering LDL cholesterol in older patients and readdress whether older patients should be treated less intensively than younger patients. Their study population was comprised pulled from 6 articles, including 29 trials. In total, there were about 245,000 participants from those 29 trials, but of those, only 21,500 or 8.8% were at least 75 years older, with further breakdown of most of those studies being from the statin trials, but then also about 30% coming from ezetimibe trials and 16.4% from the PCSK9 inhibitor trials. The interventions they were all studying were lipid-lowering therapy or more intense lipid-lowering therapy, and the comparison was to placebo or less intensive lipid-lower therapy. And the major outcomes that they were interested in were the major vascular events, all-cause mortality, and safety endpoints to make sure that lipid-lowering therapy is not causing more harm. Their inclusion criteria that they had was looking specifically at randomized controlled trials, and all those trials needed to study cardiovascular outcomes. They only were interested in trials that were studying LDL lowering drugs that were recommended by the 2018 American Heart Association guidelines. And their median follow-up needed to be at least 2 years. And of course, all of these studies needed to include patients who were 75 years or older. Exclusion criteria were trials including dialysis or exclusively heart failure patients, and they excluded those trials because the American Heart Association guidelines currently do not recommend LDL lowering therapy in those patient populations. So they did a comprehensive review of Medline using a search algorithm, and they were able to identify about 258 potential articles. Of those that were screened, majority of them were excluded because they did not meet the inclusion criteria. And they ended up reviewing 31 full text articles, of which 6 were selected. One being the CTTC meta-analysis that I just mentioned briefly, and then additional 5 individual studies. This is the baseline, this is the demographic data for all of the studies. And as you can see here, the mean age for these studies were 78 years or older. And the median follow-up for these studies was between 2.2 and 6 years. So a fairly good amount of follow-up. In terms of their results, this is the forest plot that shows cardiovascular events between the statin and the non-statin studies. And lipid-lowering therapies overall were shown to reduce risk of major vascular events by 26% per 1 millimole liter reduction in LDL. And there was no statistically significant difference between statin and non-statin treatments. This is a further breakdown of all the major vascular events they were interested in. And again, they showed benefit with LDL lowering therapy for each of those composite events. They showed that cardiovascular death was reduced by 15% per 1 millimole per liter reduction in LDL. MI was reduced by 20%, stroke by 27%, and revascularization by 20%. This was a very nice analysis they did. They did a breakdown of primary versus secondary prevention and looking at major vascular events. And as you can see, the top one shows the secondary prevention group, which does show the benefit. But when you look at the primary prevention group at the bottom, unfortunately, they weren't able to show significant benefit in lowering risk of major vascular events. Of course, the caveat being that only 2 studies really looked at this, at primary prevention with very small sample size, which invariably affected power to detect benefit. Oftentimes, these were subgroup analysis of a subgroup analysis. In terms of looking at overall mortality, unfortunately, lipid-lowering therapy was not shown to benefit all-cause mortality, but as you can see, it was quite close. For random effects model, it just barely crosses 1. Then they also compared the benefit of LDL lowering therapy between older adults, so those 75 years and older, versus younger patients. And it was very interesting to see that there was no significant difference in magnitude of risk reduction when comparing the older versus the younger groups. and looking at potential adverse events from LDL lowering therapy, they did not show significant increase in any of the adverse outcomes, including cancer, non-hemorrhagic stroke, new onset diabetes, or neurocognitive adverse effects. So for clinical appraisal, I used the CEBM tool to critically appraise this study. So was the research question clearly stated? I think that it was. It was clearly stated, and it was, I think it did a good job summarizing prior evidence and study aim. Is it unlikely that relevant studies were missed? I think that it is unlikely. And they did a comprehensive search algorithm. They did not have any language restrictions when they were searching for the articles. And they also searched reference lists of all articles and reference files of all the authors. Were the criteria used to select articles for inclusion appropriate? I think the criteria were appropriate. They included comprehensive inclusion and exclusion criteria, which were based on the recent American Heart Association guidelines. Were the included studies sufficiently valid for the type of question asked? I think the answer to that is yes as well. They did also use the Cochrane tool to assess risk of bias for all the studies they looked at. And they showed that it was low risk of bias for most of those studies. Individual data was collected from most studies. The one caveat being that study participants generally were healthier and maybe a little bit on the younger side compared to the general population and the kind of patients that we're used to seeing. Were the results similar from study to study? Generally, yes. They also used a random effect model to account for heterogeneity if it was present, and it was also reported with statistical testing. So for conclusion, I think that LDL lowering therapy reduces the risk of major vascular events and cardiovascular mortality in older adults. This effect is most pronounced in individuals who already have history of vascular disease, and the magnitude of the effect was similar between younger and older patients. However, there's less evidence of benefit of LDL lowering therapy when used in primary prevention, but there's currently an ongoing prospective randomized controlled trial called the Trainir trial that hopefully will provide more information on this. Thank you, and I would be happy to answer questions.
Great. Thank you very much, Dimitri, for a very clear presentation that summarizes some new therapies since the last meta-analyses on the subject. I'm going to open it up to questions. We have a few minutes for questions. Please either raise your hand or unmute your microphone to ask Dimitri a question.
Dev, there's a question in the chat from Irene Turpey.
I'm sorry, I didn't pick that up. Dr. Turpey, Irene, please unmute your microphone if you're able to.
Hello.
I see. Was
yes.
the length of time the lipid-lowering drugs had been taken considered? So exposure to the intervention.
Yes, that was an excellent question. It was considered. They do mention it as one of the possible limitations, although the length of time these effects were studied were really lower in the newer PCSK9 inhibitor trials, and the authors believe that actually if those trials were ongoing for a longer period of time, perhaps they would have been able to show greater benefit of those therapies. And they also addressed the heterogeneity in the time of study interval in their statistical analysis models.
Thank you. And maybe, Dimitri, I can ask, do you believe that the right sample simply hasn't been studied, or do you think that older adults suffer their outcomes via a non-LDL mechanism?
I believe that these studies were definitely very useful to kind of show more evidence for lipid lowering therapies in older adults, but I don't think that they still capture the typical patients, the average population quite well, because it's good that they're looking at these patients who are 75 years old older, but having said that, a lot of them have very minimal number of comorbidities and actually need to be fairly fit and able to come for follow-ups. So I'm not sure that they're still capturing entirely the type of patients that we are seeing.
It's Barry speaking. I always find it interesting that we're asked to talk about and discuss the kinds of patients we actually don't see, right? There's nobody else to do that, but it's an interesting thing. And remember, all-cause mortality, as you know, the biologist's definition of aging is that your likelihood of dying in the next year is increasing. So that means that any relative risk declines with age, right? So it's always harder to determine these things, how much benefit there is. Even though the baseline is higher, the relative risks of any single thing like hypertension go down. So sometimes it's hard to interpret the studies. The one exception to that from the Framingham study is atrial fibrillation. The relative risk is unchanged, which is why we're so keen on managing that, because it is such a lethal event.
Thank you. Gary has his hand up. Please, Gary, unmute.
Thank you, Dimitri, for a nice presentation. I was only able to review this paper fairly quickly, but based on the abstract and the discussion, I didn't find that they provided real clarity about or separating primary versus secondary prevention. I know that the tables had some data. When you finish reading the paper, do you have, I guess, a strong conclusion for yourself in terms of how you would approach older adults with secondary versus primary prevention?
I think that most of the evidence that they analyzed was geared towards secondary prevention, and really most of the studies were interested in looking at patients with secondary prevention. In terms of primary prevention, they only were able to find 2 studies that had any patients with primary prevention, and of those, it usually would be a very small sample. So it was like a subgroup analysis of a subgroup for those studies.
If
so
I can just
think,
add, if I can just add quickly, it's actually supplemental figure 2 has it broken down by primary and secondary prevention. And so that's the thing is, sorry, Dimitri, everything that I heard of your talk was really great. I had trouble logging in. It's Genoa here. But in supplemental figure 2, they have it broken down that way. And so kind of what we already know, that in secondary prevention at least, it looks to be helpful, but in primary prevention, not. Do you have that there? Okay, good.
Yes.
Okay.
Yes, but what I think is a major caveat here is that the number of patients under primary prevention is very small. So I wonder if they just don't have enough power to make a decisive conclusion on primary prevention specifically.
Thank you very much for that great discussion. With that, due to time, we'll have to move on. Dimitri, I'll kindly ask you to stop sharing your slides, and thank you again for a great presentation. And next, we welcome Dr. Carla Rosario back to Journal Club from parental leave. From her choice of articles, she has not missed a step. A very timely topic, the effectiveness of e-interventions on fall prevention. As a reminder, before Carla starts, please everyone remember to mute your microphones. And from the participation, it seems that most people were able to register. If you hear of anyone having difficulty, please direct them to me. Carla, over to you.
Great. Good morning, everyone. I'm happy to be back presenting here at Journal Club. So today we will talk about this article that was published this past October, the effectiveness of interventions on fall, neuromuscular function, and quality of life in community dwelling older adults. And it's a systematic review and a meta-analysis from a group in Singapore. I have no conflicts of interest to disclose. The objectives of the presentation are three: to review the evidence related to virtual interventions to prevent falls in the elderly, to critically appraise the study, and to facilitate discussion about the implications of virtual interventions in this era where in-person visits and in-person programs are either reduced in numbers or canceled. This is what we were used to see before when we were recommending patients that were referred for falls and patients that were suitable for fall prevention programs, where in this types of setting, there was a sense of security that our patients were in the great hands of the physiotherapists. And then there was also, the socialization. There was the sense that at the end of the program, we would have measurable outcomes, whether it be in improvement in balance or strength, that would give us some reassurance that we would decrease the risk of falls in the future. And then this happened. Oh, sorry, 1 second. And then this happened. A picture that was heartbreaking to watch back in March, and it's heartbreaking to watch now, regardless of how many times you see it. Our patients didn't have contacts with their loved ones, but also didn't have contacts with their healthcare providers or the teams that work with us, for example. I'm having some problems forwarding my slides, sorry. Oops. And our local institutions quickly turn to virtual care, and in many shapes and forms. It has certainly been something that has been used for many years, and is certainly widely used now more than before. We're turned to a reality where the majority of our recommendations now need to take place in the patient's home. And when it came to falls, then a big part of the solution was home-based exercise. The textbook solution then was, well, physicians and allied health professionals can use telemedicine to provide consultation, assessment, and interventions. And all you needed was a mobile device or a tablet, high-speed internet, a home area clear of obstacles to exercise, and an assistant or an auxiliary device to help with balance. And this is the picture-perfect idea what this might look like. Two very fit older adults doing yoga in a very spacious and clean environment. A much older adult, maybe watching exercises or videos on a tablet, wearing earpods and possibly video calling someone else at the same time. Or the last picture, a much older adult using a Pilates ball. And this gave us some reassurance that maybe some of our patients were up for that challenge. And maybe some of them are. Maybe some of them are doing just fine at home and look like these pictures. But the reality is certainly a bit more chaotic for the most part. Zoom fitness classes are being offered by many of the senior centers in Toronto. The classes are packed. People are trying really to make the best of what they have. And this is what the classes really look like. We know that preventing falls in older adults is important to ensure they live in a fulfilling and meaningful quality of life in older age. And data from the CDC really shows that the fall death rate is only increasing, and it was predicted by the year 2030 there might be as many as 7 fall deaths every hour, and this was irrespective of the COVID-19 pandemic. COVID-19, as we know, is severely impacting older adults in their lives in many more ways than we predicted. And we know the physical distancing is a double-edged sword for our older patients. Decrease in physical activity leads to decline in mental health and decreased quality of life, also worsening chronic pain, which increases the risk for falls. Not seeking medical attention regularly and decreased visits to healthcare providers, leading to worsening symptoms of chronic illness, but also worsening polypharmacy issues also increase your risk for falls. Increasing loneliness and depression has numerous consequences that include cognitive and physical decline. The limitations of access to group programs, such as the ones that we are used to offering in our institutions, is certainly leading to an even faster rate of caregiver burnout. So it will not be a surprise to us that as we go through the pandemic and come out at the other end, the patients that we see in our clinics will most likely be worsened in almost all areas of our geriatric review system. So we wonder if falls will be the new pandemic in the post-COVID era. And some people are hypothesizing that in the coming months to years, there will be a substantial increase in the number of falls in older adults as a consequence of less physical activity during the COVID-19 pandemic. And this will certainly lead to an increased number of deaths and disability amongst our patients. We know that physical exercise is one of the main fall prevention strategies, which may save many lives. Therefore, home-based exercises involving some sort of technology is certainly an alternative that we must look into. And most of us believe that some exercise and some human connection is better than none. But is it going to work? And this paper is the first systematic review and meta-analysis evaluating the overall effect of interventions for fall prevention. A fall is defined as an event in which a person unintentionally comes to rest on the ground, the floor, or a lower level. And besides the immediate physical consequence to the faller, there is financial, emotional, and social repercussions of falls that reverberate through multiple levels of society. Falls may result in serious and permanently disabling consequences, such as hip fractures or TBIs, amongst other things. And treatment of falls take a lot of manpower and resources in the acute and the primary healthcare sectors. So preventing falls certainly is one of the key factors to ensure that people can maintain a high quality of life in older age. We have traditional interventions that we have been practicing for many years that include exercise, such as exercise forms such as Tai Chi or yoga, resistance training, aiming to increase muscle strength and improve balance, which reduce falls and significantly improve functional performance. In addition to multifactorial prevention interventions, such as medication reviews, home safety assessments, and modifications, vision correction, vitamin D supplementation, and education. But we also find that now we have, and they've been studied for many years now, interventions. And this study highlights 6 groups or 6 categories of interventions. And we'll go through each of them before we actually get into the data of the study. The first one is the one that we're most familiar with, and it's telehealth. It involves communicating with the patient over telephone or video calls. The combination of telehealth and exercise is a common prescription in many countries. And telehealth and exercise certainly is a form where the healthcare providers, such as the physiotherapy, or in some countries, even a private coach will connect with the patient over a tablet and provide real-time feedback and encouragement, therefore providing improving performance and improving adherence, because there's someone they're always coaching you. Smart home systems aim to decrease environmental hazard to forecast potentially impeding falls using sensor technology. And 2 main examples are used in this study. The first one being passive vision-based sensors, the nightlight path automatically switching on when movement is detected. And this increases nighttime visibility and guides elderly to light switches and toilets. It aids in the negotiation and the walking around obstacles in low light, reducing the risk for falls. Then there is wearable sensors that can help with detection and prediction of falls. So we're, I think, more familiar with these ones, that if a fall occurs, an electronic bracelet triggers the remote intercom. And that connects the patient to a central hotline around the clock phone support. And so and that is here in the picture on the right, basically, oops, apologies. these are the lifeline examples of wearable sensors, as well as the home devices. And then here on the left, I just literally screenshot some of the vision-based sensors that people can purchase. And I just found this from a Google search. And certainly the price, it seems like it's easily acquirable. The prices vary between $3 and $15 each, but they're certainly quite attainable, and they're popular. Socialized exercises are exercise programs conducted via tablet or a computer app. These are almost like virtual gyms tailored to individuals' abilities, and they have an option to increase difficulty as the participant becomes more fitter. And these apps aim to strengthen balance training, sending motivational messages and allowing participants to contact a physical training for consultation. I took a screenshot of one of the apps that has been studied in the trial in 2014, and it's called the Active Lifestyle app. And basically, just to use some examples, there are exercises like the one-legged stand. It tells you, do this for 15 seconds and move on, switch legs. You enter the information on different screens. You're able to rate it. And the socialization part is that there's live on chatting with people who are using the same app either at the same time or on the same day. And you can also contact, as I said, the physical trainer for consultation. This is just one of the apps that have been studied in the trial. However, there are many other apps that one can use. And when you, again, look for apps that are targeted for our patient population, there are several ones that are free. There was a top best 6 free apps for people over 60 that I saw in my quick searches. And so certainly they are attainable. Computer-based cognitive training usually takes the form of sit-down games on computers. And either is it games that target different cognitive functions or just exercises, but the whole goal is to improve executive function requiring minimal supervision because you're sitting in front of the computer. And it has been shown in trials that intervention does have an impact on fall reduction. And cognitive training in some European countries is also combined with non-gamified exercise programs in order to maximize the benefit for that cognitive motor training. In this 2017 study, the computer-based cognitive training task was done using different commercial packages that had different cognitive functions, such as like attention or working memory, etc. And so, just as an example, for example, the training program for the intervention group was having a session of about 45 minutes, an hour and a half each, 3 times a week, for example, for a period of 3 months. And they were guided by a teacher. Another form of an e-intervention is non-conventional balance training. And this also has been studied for several years now. And it is meant to help improve balance control by providing feedback for correct posture, for example. And these are body-worn sensors that detect body position and provide visual and auditory or tactile cues to the user when the body is in a type of precarious position. And you can adjust the body accordingly based on the feedback that you receive. And it's certainly, it's an interesting way of receiving quantitative data back and, as I said, live feedback to sort of correct your posture. And this has been studied. The latest study was in 2018, and this picture here is what they've used. Basically, it has 2 places for input that the patient wears like a belt on the waist, and then they carry a cell phone for feedback. And as far as I know, based on my quick research, there isn't a commercially available equivalent of this, and this has mainly been just for research purposes. Gamified exercise or extra games are forms of exercise typically using motor sensing technology to detect players' movements. So an example of this are treadmill training with virtual reality, dance games, or bingo. And they simultaneously engage cognitive motor areas in the brain, addressing both physical and cognitive aspects of balance. And it has been shown that this gamification of exercise increases adherence due to their fun and engaging nature. And the overall outcome for this is really to achieve cognitive motor training, to improve cognitive motor training. These two examples of two of the studies that I picked are just to have a visual idea what this looks like. The first one is the randomized control trial in 2016, published in The Lancet. Participants were of ages 60 to 90, approximately 150 on each arm, 5 centers across 5 different countries in Europe. And they compared treadmill training alone versus treadmill plus virtual reality. And the virtual reality system was consistent of a motion camera, as you see here in one of these red squares, and a computer-based simulation projected into a large screen like this one up here, which was specifically designed to reduce falls risk. It included real life challenges of sort of walking in a path. And so it had obstacles, it had multiple pathways and distractors that required continual adjustments of the steps. And both groups aimed to train 3 times a week for about 6 weeks, and then each session was lasting about 45 minutes to an hour. I believe the primary outcome was incident rate for falls during 6 months after the end of the training. And the result was that the incident rate was significantly lower in the treadmill training plus the virtual reality group. The other example is this other study from PLOS ONE, single blind, smaller, certainly smaller trial comparing the step pad training versus no intervention. And this is very similar, like the pads are very similar to what we know are the dance pads that we use for kids. And this study also showed positive results. So the aim of this study was to synthesize new information to add to the current body of knowledge regarding the effectiveness of e-interventions on fall, neuromuscular functions, and quality of life in community-dwelling older adults. And the study had several objectives. The primary outcome of this review was proportion of fallers, and 2 was improvement of balance. The secondary outcomes was lower extremity strength, looking at fall efficacy, looking at cognitive function, and quality of life. The inclusion criteria was older adults over age 50, and the definition of older adults, the author were very clear that really changes across countries, but they use the recommendation from the WHO that accepted age 50 as a realistic working definition in certain parts of the world. And so that's why they picked it. So older adults over age 50 who experience normative aging and live independently in the community or assisted living facilities. And also, as mentioned, the PICO framework guided the selection of eligibility. The exclusion criteria was older adults living in long-term care and nursing homes, and studies also of patients that only included patients with Parkinson's disease. The interventions included were many, and they're listed here, but certainly they were grouped in the ways that in the 6 groups that we went through already. The comparator interventions included standard physiotherapy or exercise, education without the use of a mobile application, standard care, or no intervention at all. And the studies require at least one of the outcomes that we went through, the primary or the secondary outcomes that the authors had. So the selection process. So here is the PRISMA diagram for the systematic review. The search strategy was composed of a 3-step search done for all the relevant RCTs that were recommended by the Cochrane Handbook for Systematic Review of Interventions. And as you see here on the top, the 9 online databases were searched for all published work. They also had a hand search that was done of relevant RCTs, producing 4 more relevant results. A total of about 1,700 records were gathered, and after removing duplicates, over 1,300 remain. All abstracts of the 1,300, all abstracts were reviewed by 2 independent reviewers, and the ones that did not have keywords in the title and the ones that did not meet the eligibility criteria after reading the abstracts were removed. Finally, 119 records with corresponding full texts were screened according to the eligibility criteria. 31 articles met the criteria, and out of those 31, 26 were included in this meta-analysis, with 5 studies that were excluded and they were used for narrative review. The quality assessment, so they used the GRADE approach to summarize the quality of evidence for the studies, analyze and the strength of the recommendations. The assessment of bias was done for each RCT and individually assessed by the reviewers for the risk of bias to reviewers +1, an extra one if there was conflict. And they used the tool developed by the Cochrane collaboration as well. Funnel plots of asymmetry were used to test potential publication bias and identify outliers. And 6 domains of bias were assessed, each domain rated as high, low, or unclear, with the reasons reported for each judgment and the evidence. The meta-analysis was done using the RevMan Manager software and was used for quantitative data synthesis. Heterogeneity across the study was assessed with the chi-square test as well as statistics. Studies with increased heterogeneity were excluded from the meta-analysis but reported narratively. And heterogeneity was improved by extracting the studies into different groups, and there were subgroup analysis done. The results of the study included the results of the meta-analysis included the 31 studies, and that represented over 4,800 older adults age 50 or above. The average age was 77.7 years old. Most studies delivered one of the 6 forms of interventions that we have described already. And the studies were conducted across 17 different countries, and some studies were certainly conducted in many countries at the same time. So the results are represented in several forest plots. And starting with the effect of interventions on proportion of fallers. 11 studies reported the proportion of fallers, and a total of 2,500 participants were included in this meta-analysis. The number of falls was a self-reported measure where individuals or family members reported the falls that occurred in the monitor period. And the lower risk ratios, this is how they're expressed here, the lower risk ratios indicate a decreased proportion of fallers. As you see in the bottom diamond of the forest plot here, the effect of e-interventions in reducing the proportion of fallers in intervention group here was statistically significant, favoring e-interventions to traditional interventions, as determined by this random effect method. E-interventions reduced falls risk by 21%. However, the heterogeneity test here suggested that there was moderate heterogeneity across the studies, and therefore they did a subgroup analysis to examine the effects of the intervention types on the proportion of fallers. And all 3 e-interventions certainly showed risk reduction, but the Smart Home system showed the greater reduction than telehealth on exercise and or telehealth only. So the second set of results describes the effects of e-intervention types on balance. Balance really consisted of different types. So either was static or dynamic, and this was measured in a variety of ways. But most studies included the Berg balance scale, the BBS. It's a common measure of balance, and this was used in this review. So there were 10 studies that represented represented 653 patients which were pooled in this meta-analysis. So the BBS is a 14-item objective measure that is used to assess static balance and falls risk of older adults. And we use it in some of our day treatment hospitals, certainly for research is used more widely. And higher BBS scores indicate better balance. So the effects of the e-interventions in improving BBS scores is shown here at the bottom as well. And it was statistically significant, although it had a small size, a small effect size. favoring E interventions. And so this first plot is actually of the standard mean difference. So the intervention side is on the right. And because of the heterogeneity being moderate, again, then there was a subgroup analysis conducted to examine the effect of each E intervention type on the VBS score and balance. And only the telehealth and exercise interventions show statistical significance. Improvement in balance and statistical significance was not found in the other 3 types. Now into the secondary outcomes, effective E interventions on lower extremity strength. 6 studies were reported in this group, and the short physical performance battery was used in the meta-analysis with 702 participants. And the SPPB is a 3-part objective measure of lower extremity strength. Higher SPPB score indicates better lower extremity strength. And if you the effects of the E interventions here, improving SPPB scores, unfortunately, was not statistically significant. And even after they did a subgroup analysis, most of the type of interventions did not show statistical significance in improving the lower extremity strength. However, the authors did mention that in the most part, the types of interventions favor the intervention group, but there was no significant difference. Effective interventions on types of fall efficacy. 6 studies reported post-intervention ABC scores, and that is activity-specific balance confidence scale. That was included here, and is 429 participants included in this particular meta-analysis. The ABC is a 16-item subjective self-report measure assessing confidence and performing some ambulatory activities without falling. So higher score meant better fall efficacy. And the effect of the interventions in improving ABC scores in the intervention group here was statistically significant with a small effect size, favoring the interventions determined by the randomized effect methods. And heterogeneity was tested, and it was seen that the test suggested homogeneity across the studies. So the results on E interventions on cognitive function unfortunately did not show statistical significance. And the cognitive function evaluation was done using trail-making test A and B, and similarly, the effects of the interventions on health-related quality of life using 2 different scales did not show a statistical significance either. The publication bias was assessed using the funnel plots for outcomes with more than 10 studies. And what you see here are the funnel plots for proportion of fallers and balance. And they were symmetrical and equally distributed.
Carla, sorry to interrupt. There are 10 minutes remaining.
Thank you. So the summary of findings is that the interventions improve balance and fall efficacy scores and decrease the proportion of fallers that were not able to significantly improve lower extremity strength, cognitive function, or health-related quality of life. Of the interventions evaluated, telehealth and exercise and smart home systems showed the best evidence of effectiveness. So for the critical appraisal part, did the study address a clearly focused question? I believe they did. It was clear. It described the population, the intervention, and the outcomes of interest. Is it likely that important relevant studies were missed? I didn't think so. Their search was quite thorough. They were manual searches. They also contacted authors of unpublished studies, and the search strategy included both the control vocab terms and the text words, and all that was included in the supplemental material. It wasn't clear to me though that the studies were just were done including all languages and different articles, of different languages, but it was not specifically stated. So I think that they were only limited to English, if I'm not mistaken. Were the criteria used to select articles for inclusion appropriate? Yes, the inclusion and exclusion criteria were defined a priori. However, there was no justification for not including patients with movement disorders. Were the results similar from study to study? Certainly, they showed their heterogeneity calculations. In the majority of cases, when heterogeneity was moderate, then the chi-square tests were done and subgroup analysis conducted. Were the included studies sufficiently valid for the type of question asked? I believe so. The methodological quality of each group was assessed using the grade quality framework with 2 independent reviewers and a third author if needed. When the quality of data, when the quality of data balance was rated low, it was still analyzed and included. So that wasn't very clear to me of why that was the case. And there was certainly a limited number of studies that reported outcomes such as quality of life. That definitely affects statistical significance and power. Are the results generalizable and applicable to our patients? Yes and no. I mean, the average age was pretty reasonable, 77.7 years of age, and certainly falls is a common issue that we see in our clinics, and we're all looking for ways to improve our recommendations. However, this was a healthier, older population than what we usually see, and they didn't really examine the interaction of risk for falls and comorbidities, which is probably one of the biggest drawbacks of this study. The strengths is that this study certainly attempted to summarize the efficacy of virtual interventions for prevention of falls, but there were several limitations that include sample size in the study groups, many factors that influence risks that were not accounted for, such as we said, health status, but also ethnicity and social economical status. And some of the measures for balance or cognitive function were quite limited. And we know that certainly they don't represent comprehensive, for example, cognitive function. The implications is that this really provides evidence that interventions could be a suitable alternative to in-person intervention in the right patient population. It does identify some strengths of the interventions that we're currently using. So telehealth can be effective in preventing falls, but should be combined with exercise regimens for better results, and they probably should be supervised. And smart home systems, which we often do talk about when it comes to lifelines or night lights, certainly improve fall-related outcomes based on this study. And there might be a role for e-interventions to improve fall outcomes and balance. Future research should certainly focus on doing more studies with a lot more power in these areas. And I believe given our current situation, that probably will be the case. And socialized exercise programs, although it did not show statistical significance, there have been some RCTs that have shown some correlation that socialized exercise programs, such as the exercise sim classes that we see, show a benefit in fall prevention. And so the challenges then become, as we look ahead, access to physical exercise programs will be limited due to the increased waiting list of more deconditioned patients. And it will be difficult for patients even to come to our programs. And so we do have the need to sort of to think about other sort of home-based strategies for fall prevention that might involve technology. And so the need is certainly there. So with that, I'll end, and I will be happy to take questions.
Thank you very much, Carla, for a great presentation, bringing forward evidence on our rapidly changing models of care. Can I ask, am I accurate to say that the Zoom-based exercise class in the meta-analysis did not turn out to be one of the positive outcomes?
Yeah, that is the case. Yeah.
Okay, I have a comment from Carol Cohen. Given the positive results for smart home systems, particularly night lights, would you be more likely to recommend them, and where should they be located?
Yeah, and I think so. I was that's what I did a quick Google search, because I was looking at how accessible are these, and I think that I now, after this paper, would be more willing to recommend them. They seem to be, like I said, they vary in price, $3 to $15. You can buy them. I saw them in well.ca or Amazon or Walmart. They usually are or should be placed in stairs if there are, especially if there's a need, people who get up at night and like take a snack and the kitchen is in a different level. So you can put them there on the walls and not on the steps. And then places where they have been studied and they've been placed for these interventions have been in bedrooms, lighting the path to the bathroom. And hallways, but I've seen the studies have really focused on going from the bed to the bathroom.
Very good. Any other questions or comments? Another comment in the chat box from Murray Norris. Excellent presentation, Carla. Very comprehensive and clear. Good explanation of statistics and relevant to our current situation. Challenge of equity of access for our frail seniors.
Certainly.
Any other question? Shabir has his hand up. Please unmute Shabir. Thank you.
Thanks, Dov. Carla, again, I'll echo that this was a terrific presentation, very rich with lots of examples. I have two questions or a comment and a question. The one is, you gave an example, well, I guess you gave two examples that I want to get clarification on. One is, I'm not sure how motorically stimulating bingo is compared to many of the other exercises. So I think we have to be careful in sort of lumping versus splitting. And Lifeline, you gave an example that it may help with falls, but I think the conventional Lifeline, unless others can correct me, that is sold, for example, and I know it's only one proprietary device, it is not associated with any fall detection technology because it doesn't have any vertical sensors in it. People just press it if they've fallen or for other reason they need to activate services. But there are several companies that offer newer devices that do allow vertical or displacement sensors so that if people suddenly change position, it will automatically trigger. So I just wanted you to clarify that, please.
Yeah, I think that in the studies, I think it was in the 2018, but I'll double check in the 2018 or 17 study, that's what they tested. It was the Lifeline, like it was the sort of sensor, the Lifeline equivalent, the sensor's position. And there was one that sensed it, like, you don't have to be vertical to be able to activate the sensor, but it gave warning when there was 45 degrees and when it gave a noise. That was my understanding. And certainly it's the sensors that were studied and not the ones that you would push to activate the 24-hour help. It's the ones that get activated when you reach the ground or when you change position suddenly.
Yes, there are two comments from Carol Cohen and Barbara Liu that Lifeline does have accelerometer technology now. There is the option for it. I'm sorry, Shabir, I muted your microphone. If you'd like to comment, please unmute.